So, a very good morning to all of you. It's indeed a great pleasure to be here for this ProCon debate, Ecmo versus Impella for the refractory cardiogenic shock. And we have two very eminent speakers, Dr. Sarita Rao and Dr. Venkat Goyal. I would request Dr. VK Sharma, who's the co-chair, and Dr. Pranay. It's indeed a great pleasure to have both of them. I would request Dr. VK Sharma to please introduce Dr. Venkat Goyal.
I welcome Dr. Venkat Goyal, and I think he has been introduced before. I love to have a talk, Impella versus Ecmo. You will be speaking for Impella,
Actually, for Ecmo.
both.
I am in a debate for Ecmo in refractory cardiogenic shock. In fact, the word refractory cardiogenic shock make my talks very simple because it's an open and shut case. For a refractory cardiogenic shock, the first choice is Ecmo. Then things can be added. So the debate of Ecmo versus Impella for refractory cardiogenic shock, using Ecmo for refractory cardiogenic shock is very simple. There are so many etiologies of cardiogenic shock. This is a sky classification for shock, in which the extremes, the E stage of cardiogenic shock is the refractory cardiogenic shock stage. Other than that, the classic stage where it begins, where mechanical circulatory devices come into existence or come into application, there other peripheral uh, mechanical circulatory support can be added. But if you talk of ECMO, then for refractory stage, the ECMO is the first line of defense. If we talk about the various types of shock, first is hypotension, then stage 2 is hypoperfusion, the third stage is deterioration, and the fourth stage is refractory shock. In refractory shock, not only the heart but the entire body takes the brunt, and there is deterioration on all the fronts. So I don't think Impella can take the load of correcting all the problems. This is a series of deterioration in which you have to look at hypovolemia, acidosis, lactates, tissue perfusion, hypocalcemia, inotropes, the renal dysfunction, the liver dysfunctions, everything that sets in to make it a refractory shock, where you require a complete hemodynamic support, circulatory support, and a tissue perfusion support, which can only and only be provided by ECMO. This is again the same thing, the various types of components in biochemical markers, the hemodynamics and the physical examination. If I have used the word refractory, then these detained parameters cannot be supported by Impella alone. This is just a comparison of ACC classification, the NYK classification, the Intermex classification, the SKY classification. They all points that if we reach to the end of uh, almost collapsing situation, and most of the studies says to apply a peripheral mechanical circulatory support when they are indicated, then perhaps at that stage of extreme deterioration, ECMO is the only rescue. This is just to tell you the picture in which the cardiogenic shock stage here. These are the possible available options of it to you for using support, in which intra-aortic balloon pump impact and impella and tandem heart are till stage 3 or classic stage of cardiogenic shock. If you go to deterioration and extreme stage of cardiogenic shock, then perhaps it is ECMO and ECMO alone. The circulatory support part is what is the extra component in ECMO which cannot be given by Impella. Of refractory shocks, there can be many more types of shock like hypovolemic, cardiogenic, obstructive, and vasodilatory shock. According to me, Impella is only indicated for an acute MI cardiogenic shock for an intervention procedure inside the cath lab. More than that, it cannot correct anything further. The same thing, there are so many types of dissociative shock, and they have their implication at the periphery, which alone Impella would not be able to correct. This is just to show you the increasing arena of deterioration from the coronaries to the cardiac muscles, and the cardiac muscles to circulation, and circulation to tissue perfusion, and from tissue perfusion to derangement in all periphery of the body. So The important part is tissue perfusion, which is the uh, cornerstone of refractory cardiogenic shock. So, if the tissues are not perfused, then the protective forces lose their control and damage the body more. The compensatory mechanism like neurohumoral activation pathway, the central sympathetic pathway, the renin-angiotensin cascade, the endothelium releasing factors, the endocrine renal and biochemical markers, the cardiac dysfunction, systemic vascular resistance, ventricular remodeling, they all make it a refractory cardiogenic shock. Here again, the same thing is very well highlighted in the sky cardiogenic shock stage, which says the stage E extremis is hypoperfusion with deterioration and refractory shock. Till stage D, it is a non-refractory shock. So if I want to apply peripheral mechanical circulatory support, then ECMO is, these are the five stages of the cardiogenic shock stage. ECMO will begin somewhere in the classical stage. The maximum application of ECMO is in the refractory cardiogenic stage. Impella is in classical cardiogenic shock for mainly acute MI cardiogenic shock and will lose its application as you go to stage D or E, though it can be used as a supportive device for cardiac stunning. But ECMO has so many alternatives to handle cardiac stun and be more economical about it rather than to use Impella only for cardiac stun. So Impella has an application to stage T of cardiac shock, more in classical acute myocardial infarction cardiogenic shock, whereas ECMO has an application to all sort of refractory cardiogenic shock in stage E, and where it is the first line of defense. This is just to show the increasing level of support as you go on. Ultimately, VA ECMO is the rescue to the final stage of deterioration where Impella and tandem heart scores at the second and the third stage. This is just the pressure volume loops and the pressure relationship. The VA ECMO is slightly unphysiological to cardiac muscles, but then it is very much supportive to the peripheral circulation. And these are the various types of mechanical circulatory support available to us. If you look at the machine console, although this is the Ecmo machine, and this small unit here is the Impella device, how can you think this small device can be an alternative to such a robust mechanical circulatory support through Ecmo? So if you have to support the entire body to pump around 5 to 6 liters of blood, then perhaps Ecmo is the only answer. If for all types of conditions where temporary support is required, like electrical storm, acute MI, percutaneous valve replacement, tachycardia, induced cardiomyopathy, to acute cardiogenic shock of acute MI, papillary muscle dysfunction, post-cardiotomy shock, acute decompensated heart failure, to patient with pulmonary hypertension and with pulmonary embolism and other things, with high risk procedures to bridge to recovery, to bridge to decision, alone Impella would not be able to handle most of the conditions. Therefore, if you require an adequate oxygenation, then impeller stands nowhere. If it is a condition with adequate oxygenation is not there, then ECMO is the only answer to you, not impeller. This is again from cardiogenic shock to refractory cardiogenic shock stage where the peripheral circulatory failure takes place and tissue perfusion is inadequate. So the ECMO comes into picture. This is again the cascade to show you that ECMO is higher or later stage application for failing heart or failing tissue perfusion after and impella or tandem heart. So this ECMO stands in the later stage to support the body. Of all causes of cardiogenic shock, if you see the acute MI cardiogenic shock is much lower than non-acute MI cardiogenic shock cases, and which they are increasing. So ECMO has an application for non-cardiogenic shock cases. Of the only difference between the types of temporary mechanical circulatory devices, the LV venting is only a negative part of ECMO application as compared to Impella. And if you look at the figures of the clinical outcome of Impella versus ECMO in various studies, the 30-day mortality was not much different as compared to Impella, which they claim that they do a good ventricular unloading, but all cause success rate is almost nearly the same. If we use early application of ECMO in versus the conservative treatment of cardiogenic shock, then with VA ECMO, the p-value for primary endpoints is significant, and need for another mechanical circulatory device is much less as compared to conservative treatment where it's just 25 versus 10. Here also the p-value is significant. If you talk about the management of refractory cardiogenic shock, VA ECMO versus Impella, Impella requires a cath lab. It is only a univentricular support. There is no respiratory support. Whereas ECMO, it is an ease of application anywhere from casualty to the ICU. It is a biventricular support, and it offers our respiratory support particularly as well, and it is much far economical as compared to Impella device. If we talk about which device is better, then our miniaturized percutaneous ventricular assist device versus an ECMO with cardiogenic shock. The Kaplan-Meier code shows that ECMO in the early initial 20 months of application is better than even Impella, though the endpoints after a period of around 60 to 80 months is the same. If you talk about LV venting as the only negative aspect of ECMO, then the overall incidence of LV distension is 7%, and a subclinical decompensation is around 20%. And of that 7% also, it may not require essential application of Impella, because there are so many methods of LV venting within the ECMO system itself, and which an intra-aortic balloon pump, which is at least 60 times economical than an impeller device, could very well be used as a bailout situation for distension of LV and LV venting. So therefore, refractory shock and Ecmo is a must with or without Impella. But for a refractory cardiogenic shock, Impella cannot stand out independently as a sole helping agent for a complete circulatory failure. If we compare a meta-analysis of VA ECMO with or without Impella in patients with cardiogenic shock, then the answer is that the patient has, when both are applied together, V-ECMO with an Impella, the concurrent ventricular unloading with Impella has a lower likelihood of short-term mortality and a higher likelihood of possibility to progression to durable VAD. But they have higher rates of hemolysis, limb ischemia, renal failure, continuous CRRT therapy, and cost factor, the first. So we agree that ECMO with or without Impella is a better option than Impella alone in the management of advanced or refractory cardiogenic shock secondary to acute coronary syndrome, MI, or other causes. In conclusion, ECMO gives you a circulatory support for tissue perfusion. It gives the biventricular support for RV failure. It gives a respiratory support. If I have to say, an ECMO takes care of 5 organs in the body: the heart, the lungs, the tissue perfusion, the renal replacement therapy, and the hemo perfusion or the hemorrhology. No other equipment in the entire medical equipment has the feasibility and the possibility to support 5 organs at a time and with a replacement mode, not with a assist mode. So this is a great device. It is in a fluid state. It can be modified. It can be tailor-made to the requirement, and it can be switched over from one right side to the left side. So therefore, this fluidity of this ECMO circuit is a great advantage for tailor-making the support according to the requirement of the patient. ECMO is the only device which can be extended to destination of bridge therapy. Impella, we have to come out within 5 to 6 days. If you look at the number of centers of ECMO versus the Impella in our country also, if they are in double figure, ECMO centers now are in triple figure. The cost factor is definitely a very important consideration for our country. And IBP and venting is an alternative to the cardiac stun for which Impella may not be required. Thank you very much.
Now we'll go for the opponents about the Impella. Dr. Sarita Rao, she is a director International Cardiology, Apollo Hospital, Indore. She has an online talk.
Thank you very much, sir. But because it's Dr. Sarita, I can't hold myself. Just giving a brief introduction. Dr. Sarita, she is the director of interventional cardiology, and she's the first interventional cardiologist in central India. She has to her credit several live cases performed in most of the interventional conferences, including the TCT. And Impella is very dear to her. She's done several Impella cases, and she'll be talking virtually on the role of Impella in the refractory cardiogenic shock.
So, good morning, everybody. I'm going to be speaking about Impella versus Ecmo today. Now, at the onset, today in this discussion, we are searching for an ideal mechanical circulatory support for cardiogenic shock. And as for other mixed shock without predominant LV involvement, isolated Impella would not be the choice at all. When we talk about cardiogenic shock, it complicates acute MI in about 5 to 10% of our cases and remains the leading cause of mortality in patients with acute myocardial infarction. Cardiogenic shock is associated with mortality rates almost as high as 40 to 50%, and in spite of timely reperfusion and improved medical therapy over time. In addition to revascularization, maintenance of adequate end-organ perfusion to prevent irreversible ischemia and multi-organ failure is becoming increasingly recognized as a key target in patients with acute myocardiogenic shock. Now, where the inotropic and the vasopressor therapy is inadequate, the hemodynamics may be improved with the use of mechanical circulatory support devices. There are major clinical trials and meta analysis. However, they are yet to identify a difference in mortality with commonly utilized mechanical circulatory support devices, such as the IABP. Also, several more potent alternatives have seen an increase in the uptake and use over the past decade. There still remains a paucity of the randomized evidence for the axial flow pump, the LVSS devices like the Impella, and also for the veno-arterial extracorporeal membrane oxygenation over standard therapy in patients with cardiogenic shock. We are still a country where these devices are actually very costly, so we need to be very pragmatic in choosing one over the other. And today, this is what we will try to decide. So Impella is a continuous flow pump which is inserted. If it's a Impella 5, you would have to insert it surgically. And if it's a 2.5 or a CP, you can do it percutaneously. So it basically extracts the blood from the left ventricle with an active propulsion into the ascending aorta so as to decompress the left ventricle and provide a forward cardiac output. Impella is commonly indicated in the treatment of acute myocardiogenic shock due to a predominant left ventricle failure, where its therapeutic effects would include mechanically unloading the left ventricle, improving the forward cardiac output so as to sustain perfusion to vital organs, and also reducing the pulmonary congestion and ameliorating the pulmonary edema and augmenting coronary artery perfusion to relieve myocardial ischemia. Now, VA ECMO is an alternative high output mechanical circulatory support modality. This is classically indicated in acute myocardiogenic shock, but additionally it provides the therapeutic benefits among those with circulatory and respiratory collapse due to a cardiac and respiratory arrest or those who have more advanced vital organ dysfunction. What is the rationale and the indication for mechanical circulatory support in cardiogenic shock? Well, the left-sided percutaneous ventricular assist devices, this is primarily aimed to reduce cardiac output in patients with cardiogenic shock in case of cardiac arrest. There are, however, no randomized clinical trials which address the optimal timing or selection of the percutaneous ventricular assist devices in such situations. Now, outside the cardiac arrest setting, the usual practice is to initiate a percutaneous ventricular assist device in cardiogenic shock as soon as possible before there is the onset of a multi-organ failure. Then it doesn't work so well. In patients with cardiogenic shock complicating an acute MI, the registry data suggests a higher survival rates with device placement before revascularization than after in patients with acute MI and cardiogenic shock. Until we have high quality data, the decisions regarding the timing of this initiation are therefore based more on the risk and the benefit assessment, which would include the severity of shock and the burden of comorbidity as evaluated by the multidisciplinary shock team. These are the various indications. IABP has fallen out of favor, especially after the IABP Shock 2 trial didn't so much benefits. When we talk about the microaxial flow pump, yes, there are small randomized studies and cohort studies and can be used in stage C and D with potentially reversible underlying cause. And ECMO can be used as a short-term therapy in cardiogenic shock stage C, D, and A, particularly in patients who have a combined respiratory insufficiency with potentially reversible causes. So this is the hemodynamic effect of Impella. Let's understand how this works. So there is an increase in the flow, which would lead to an increase in the cardiac power output. So end organ perfusion becomes better. Also, there's an increase in the MAP. So the coronary perfusion also improves, the oxygen supply also improves. In terms of the LV, there is a reduction in the LV ADP and in the end diastolic volume. So what happens as a result of that is that wall tension comes down, microvascular resistance reduces, the coronary perfusion improves, and there's increased oxygenation. Also, when the mechanical work comes down, there's increase in cardioprotective signaling, there's reduction in the reperfusion injury. All of this leads to unloading of the myocardial recovery, so the ventricle does well. What about Ecmo? So what happens in Ecmo? Again, in Ecmo also there's increase in flow. So the cardiac power output will improve. There will be hemodynamic protection for the patient. The MAP will also improve, so cardiac power output improves. But what happens to the LV? Now the LV is in a bad situation here because there is an increase in the LV EDP. There's also an increase in the end-diastolic volume. So the wall tension, the mechanical work, all of that will increase. What will that result in? That will result in an increase in the microvascular resistance, so the oxygen demand will go up. It is actually ending up loading the heart. So, as we reiterate, the hemodynamic effect of Impella, it unloads the heart, it unloads to myocardial recovery. However, when we use an ECMO, so the MAP increases, the cardiac output increases, the power output increases, but it loads the left ventricle. So, what is LV unloading? Unloading is defined as a reduction of the mechanical power expenditure of the ventricle to minimize the myocardial oxygen consumption and reduce the hemodynamic forces that actually lead to a ventricular remodeling and in MI to reduce the infarct size. As you can see, the graph is going towards the left when you're unloading it. So, the cardioprotective mechanism of LV unloading is that when you unload the LV, now look at these pictures. So when the Impella is on, there is increased myocardial perfusion, so the oxygen supply increases. Again, there is a decreased myocardial oxygen demand, the curve is going towards the left, and there's increased cardioprotective signaling, so the cell survival improves. There is a reduction in the acute infarct size. So all of this occurs because of the LV unloading, because of the Impella. And if you look at all of the trials, the unloading pre-PCI is associated with improved outcomes in an acute MI cardiogenic shock situation. So in all of these trials, you look at the survival to explant, survival to discharge of the patient, survival to 30 days, and then again the survival to 1 year after these assisted devices. And you would see in all of them, these patients fared much better when they had the Impella to unload the LV. Now, these are the end organ perfusion effects of Impella. So, an increased flow, increase in MAP will again lead to an increased cardiac output and end organ perfusion. And cardiac power output, as you know, is the strongest predictor of mortality in shock patients. So, an improved cardiac output translates into better outcomes. Now, you can also look at the increase in the end organ perfusion with Impella when you look at the blood lactate concentrations. So, over the days when the patient has the device in, the number of days from the Impella implant increases, the lactate level gradually comes down and this patient improves. Also, if you look at the changes in the sublingual microcirculation, you can see the comparison with the Impella off and the Impella on, and you can see how the blood supply improves, the microcirculation. With the IVP, they actually showed no benefit, so that is out of favor. Now, this is an algorithm for the detection of which mechanical circulatory support device that you would need. So these patients are in cardiogenic shock, and there is a multidisciplinary heart team consultation which would involve the cardiologist, the cardiac surgeon, the advanced heart failure expert, and the intensivist. If the patient is in hypovolemia per se, you would first do a volume resuscitation, and then if the patient doesn't improve, then you would think of putting in an impeller. Secondly, if it's an LV dominant pattern, so the RA pressures are low, the wedge pressure has gone high, more than 18, the PAPI is greater than 0.9, and the ratio between RA and pulmonary capillary wedge pressure is less than 0.6, you would think of putting in an impeller. If this patient has RV dominant failure, then you would think of putting in inotropes, vasodilators. What do we mean by RV dominant? Well, we mean that the RA pressure is now high, greater than 15, but the wedge pressure is less than 18, and the ratio is again greater than 0.6, and the PAPI is less than 0.9. So these patients are RV dominant, and you would think of a right heart failure, and these patients would require an Impella RP, which is a different device. And what about if the patient has a biventricular dominant pattern type of a failure? So your RA pressure is also high, your wedge pressure is also high, your PAPI is less than 0.9. So these patients would be requiring a bipella. So you would put in an Impella CP or an Impella 5.5, and in addition, for the right side support, you would put in an Impella RP. And what about those patients in whom the cardiac output and oxygenation is also inadequate? Well, these would be the patients in whom you would think of an ECMO. So, and if with the ECMO these patients are developing LV loading, you would also think of doing an LV unloading by combining the ECMO with an impeller, and that would be a situation in which you would be using an ECPella. So in cardiogenic shock with an Ecpella, well, these patients do develop LV dysfunction with the ECMO. And what are the echo indicators? How do you decide that this patient has LV distension? First of all, if there's clot present on echo, please do not unload the LV. It's going to lead to a catastrophe. However, if you have aortic valve opening with LALV smoke and the wedge pressure is high, it's greater than 18, and your pulse pressure is less than 15, or you have a flat arterial line, you know this is an urgent situation. You need LV unloading with the Impella CP or the 5.5, and it has to be done within 2 hours. On the echo, if you see that the aortic valve is not opening, with or without the presence of smoke, and the wedge pressure is high, greater than 18, and it keeps on climbing up, your pulse pressure is less than 15, flat arterial line, you know it's emergent, you immediately need to unload the LV with an Impella CP. So these are the patient population that higher risk, severe LV dysfunction, very large acute MI, STI classification C and D, and a pulse pressure which is very low, or the patient is in frank pulmonary edema. Now, LV distension assessment also can be done if you want to look at the severity of the LV distension. Patient is on an Ecpella. You would look at monitoring methods such as the simple things, an arterial line, a central venous line, the echo, the Swan-Ganz catheter, and the X-ray. So if there's no LV distension, you would have an arterial pulse pressure greater than 15, a wedge pressure which is maintained between 8 to 12. The aortic valve will be opening consistently. The ejection fraction is good, greater than 30%. And the pulmonary capillary wedge pressure is between 15 and 20, and you would monitor for signs of pulmonary edema. And if all of these started deteriorating, then you would think of an impeller. Now, the patient who has a subclinical LV dysfunction, this patient requires urgent decompression or he's going to worsen. So his pulse pressure has now dropped to less than 15. His CVP is now rising up between 12 to 16. His aortic valve opening has reduced. Ejection fraction has gone to less than 30. And you can see the presence of smoke in the LALV. And the wedge pressure has now climbed up to more than 18 and is gradually increasing. This patient is going into pulmonary edema. Think of decompressing his LV. Clinically, if the patient is in frank LV distension, you would think of an emergent decompression if the arterial pulse pressure is less than 15 or the patient is pulseless. The CVP has gone greater than 20, the SVO2 is worsening, the aortic valve is not opening, and the ejection fraction has dropped to less than 20. You can see frank smoke, and the wedge pressure has gone very high, greater than 20, and this patient is in frank pulmonary edema. You would need an emergency measure. So, what are the problems with ECMO? Well, there are certain problems with ECMO because there's a high incidence of renal failure, neurological complication, and stroke, and a greater than 40% mortality rate. Also, there's a higher incidence of bleeding. There's more incidence of requiring blood transfusion and blood products. Also requires multiple large bore cannulation sites. There's a risk for distal limb ischemia, and perfusion is required bedside at most hospitals. Also, because it requires blood to be circulated outside of the body, there's a temperature loss of the blood. There's also loss of the platelets lining circulation tubing. There's hemodilution. So ECMO, what does it do? It loads the heart and increases the afterload. So the left ventricle tends to become distended and it struggles to eject against a higher pressure. Now, the impeller may be used at a low performance level to unload the left ventricle. Pulmonary venous congestion also occurs, resulting in an X-ray appearance of consolidation pulmonary edema, and eventually this patient also has a pulmonary hemorrhage. So, what are the consequences of an increased peripheral ECMO afterload? Well, it can be physiological and clinical. In physiological, we're thinking of increased LV wall stress and pressure work on the heart, increased metabolic oxygen demand and consumption both, and a decrease in the cardiac performance and the hypoxic coronary perfusion. Clinically, if the LV is unable to overcome this afterload, the blood within the LV and aortic root may stagnate, increasing the risk of thrombus formation and embolization. The persistent venous return from the tibial and the bronchial veins will, over time, result in overdistension of the LV, which will again increase the LV EDP and the LV end-diastolic volume and compromise the coronary perfusion pressure and perpetuate ongoing ischemia. Also, the MR may worsen or be precipitated secondary to the LV and annular dilatation, which occurs, resulting in pulmonary hypertension, pulmonary edema, and a hemorrhage. What are the methods we use to overcome the negative effects of increased ECMO afterload? Well, you can do an afterload reduction by reducing the flow or using vasodilators. Also, you can do an LV decompression. And how do you do that? You can either do an LA septostomy or you can do an LA venting or an LV unloading using the Impella, leading to the situation of an Ecpella usage. So these are the ECMO issues which increase oxygen demand and decrease the oxygen supply. And the hemodynamic effects of Impella, as we were talking about again, you would be unloading the LV leading to myocardial recovery. This is how LV venting occurs with the Impella, and you have the ECMO plus the Impella, and you have the ECMO without the Impella, and you can see the difference in the LV. So this is a paper which was published in the Journal of Clinical Medicine, and they looked at Impella versus veno-arterial extracorporeal membrane oxygenation for an acute MI cardiogenic shock. And this was a review and meta-analysis of multiple trials. What did they find? They found that there is no high-level evidence comparing the two, but in the available observation studies, mechanical circulatory support with Impella was actually associated with a reduced risk of in-hospital and medium-term mortality as compared to a VA ECMO. So, ECMO can, in all forms of shock, provide hemodynamic support, end up in perfusion as a bridge to destination therapy or recovery. However, specific to the case, it may, by virtue of its femoral arterial cannulation, retrograde supply of oxygenated blood, increase the LV afterload, potentially resulting in LV distension and refractory pulmonary edema unless an LV unloading takes place. From a physiological standpoint, Impella decompresses the LV, reduces the congestion, improves the forward cardiac output, and improves myocardial oxygenation by augmenting coronary perfusion pressure, typical to acute myocardiogenic shock, and appears to be the MCS of choice in such patients. So, as of now, with the logistic constraint, we need to unload LV, reperfuse the myocardium, decrease the PA pressure, MVO2, and Impella actually fits the bill in this situation. We do have gaps in knowledge and we do require further studies. So there are pathophysiological studies evaluating unloading of LV in acute cardiogenic shock. We need randomized trials to demonstrate if these mechanical circulatory supports are life-saving, trials to evaluate which one in which condition, trials to evaluate the paradigm shift from the door to balloon to the door to unload, protocols and algorithms to better define patient population and the timing of the mechanical circulatory support. Also, the education of the healthcare providers to reduce the device related complications which occur when you use this. Now, I'll just finish with a little case which I did. This is a patient with acute MI, cardiogenic shock, diabetic hypertensive history of CA breast, chemotherapy, radiotherapy done, had nephrectomy for renal cell carcinoma. Patient was a single kidney patient, CKD stage 3, presented with acute kidney injury on the CKD recent worsening, hypotension, failure, and presented with acute MI. This was the angiogram of the patient, proximal RCA lesion of 90%, a proximal circumflex lesion, proximal ramus lesion, and the LAD was also a long segment disease in the proximal and mid LAD. So even in ICU, Apache estimated mortality was 41%. The procedural mortality was also thought to be about 60%. It was a heavily calcified lesion, CKD, patient in failure. So we decided to go ahead, use a mechanical circulatory support in the form of an Impella. And because it was such a calcified lesion, we decided to use a rota or a lithotripsy backup. And this was the final result after using the Impella. You can see the arteries opened up beautifully. Patient tolerated the procedure well. There was no worsening. This is the RCA. This was also opened up in the same sitting using an Impella support. This patient tolerated the procedure well. And it was a good demonstration of complete revascularization in a CKD patient with ACS and LVF, which is the Achilles heel of any cardiogenic shock patient. The renal parameters did not worsen because of the support. And in trials, it's been suggested to use Impella pre-PCI for the best outcome, which is what we did in this patient. There was a lot of calcium in the LAD, so intravascular shockwave lithotripsy was used, and this was referred to as a shock Pella. So cardiogenic shock, it remains a challenging clinical problem. Patients with it are among the sickest in the hospital, and many of them die. ECMO was once the only therapy available, and it's still widely used. However, it is a double-edged sword. Complications such as bleeding, infection, thrombosis almost inevitable if it's used for long. Importantly, these patients are usually kept intubated and bedridden. In recent years, we have new devices which are easier to place, and some in the cath lab, some even at the bedside, and allow a safer bridging to recovery, transplant, and other therapies. Impella is one such device and should be used early in the course of such patients. Ladies and gentlemen, Thank you so much.
Uh, I know the organizers are very short of time, and however, it's supposed to be a debate. So I think both of the speakers have been very crisp, and they have actually placed Ecmo and Impella in their respective directions. Dr. Venkat beautifully presented that how Ecmo is very important for the physiology. For when the perfusion is reduced, we actually, and there are multiple aspects. It's not just the myocardium and the reduction in the LVEDV that we are looking at, but at the same time, he did highlight that in the acute MI situation, maybe Impella could have a role. And similarly, he did mention that oxygenation is an important thing which we cannot do without. And Dr. Sarita also beautifully presented the role of Impella, and she also highlighted that that in acute MI situation when we are in cardiogenic shock, which is refractory, Impella has a great role to play. But of course, when oxygenation and perfusion is an issue, ECMO does have a stand. We have ECPella, and I think Dr. Venkat showed us the study. When we are having ECPella, there are issues of hemolysis, renal injury, which can actually be frightening. And of course, ECPella has so far not given us an adequate data that we can use it rampantly. Um, Dr. Sarita did show in the last the meta-analysis, and if we actually look at that meta-analysis into depth, that is in patients of acute MI who are receiving Impella versus ECMO. Impella actually had an edge in cardiogenic shock due to acute MI. It is believed that there was 11% reduction in the in-hospital mortality and relative risk reduction, and around 14% relative risk reduction in medium and long-term mortality. So, of course, in acute MI situation, I think that Impella would actually help us. It's also believed that the physiological flow that we get with Impella is good in this situation. But of course, we can never forget the role of ECMO when it comes to perfusion, and we reach that stage when oxygenation and perfusion are in this. So, I would give it to my coach.
So it's more likely that if you are in early stage, probably Impella will be a better choice, provided cost is not an issue. Most of the time we get a patient coming in a late stage, so probably ECMO is an indication at that time. And if the cardiac stunning occurs, probably Impella can be added into.
For me, if it's an institute, I think ECMO, as you said, is a better perfusion technology. But if you are in moderate centers like I worked in bigger and smaller, now in smaller. There, I think Impella is a better choice. It doesn't require so much teamwork and so much management. And it can be 2.5, can be potent percutaneous, and it can save the patient's life.
So, thank you, Dr. Poonam's.
Whether it's ECMO or an Impella, we must know the place where the patient can go to. A tertiary referral center with expertise in that therapy is very essential because many people trying ECMO may fail in smaller centers. So, expertise of the person, the timing of the patient reaching that person, and the availability with the cost with the family. I think these are the choices that make it early. What we need is early for a reversible pathology. And if I say in acute MI, in cardiogenic shock, you want to revascularize a high risk PCI, I would want to come to a tertiary referral center where both ECMO and Impella are available. So that at that time, the team can decide, the intensivist, the cardiologist, the cardiac surgeon, whether I want to put in a 2.5, or if 2.5 many times may be insufficient, I want to put in a higher 5, for which you'll shift the patient from the cath lab to the OT. So those decisions have to be quick. Those decisions can only be taken keeping the cost of the patient as because at the end of the day, 50 lakhs to save a life over one day, 23 for an Impella, and maybe over a period of 20 days, ECMO of 1 lakh per day. I don't think so. It's warranted in Indian families. So we must be very careful when we talk about it till more companies come up to make this India make Impella or a India make ECMO. We must know the modality and we must keep the cost and the expertise of the team doing it in mind. It should not, the patient should not be fallback times.
Of course, ma'am, your
That's
comments are
important.
very well taken. And now that you mentioned acute MI, door to unloading time is one thing which we should not forget. So the concept of door, when a patient of acute MI comes, the concept of door to balloon time is there. But in the patient with cardiogenic shock, door to unloading time, a time of 30 minutes where you stabilize the patient and maybe introduce, it could be an ECMO or an Impella to unload the patient and then take the patient to the lab after stabilization for the revascularization. Thank you very much for the great session, and thanks to Dr. Venkat and Dr. Sarit.
Thank you, respected speakers and moderators, for this very interesting session.